I'm going to talk to you about a few things actually today. I'm going to touch on mechanical ventilation, and I'm going to go over basic mechanical ventilation with you too, so that we're assured that you have a basic idea of what mechanical ventilation is, because that plays into this presentation and showing what kind of modes we use that really only and primarily work on our burn patients. Okay, there's many modes of ventilation out there, but we use just a few. So I'm going to cover mechanical ventilation, and I'm going to touch on medications a little bit, because those medications, some of them, or I should say a lot of them, affect our breathing, our ability to breathe, our breathing pattern, and all of that. And I'm going to talk to you about forms of airway resistance also, and how that plays into this presentation also, as far as our ability to ventilate or difficulty in ventilating these patients. I'm going to talk about airway security and weaning to extubation, and then I'm going to go over some manual ventilation techniques, which I think are very important to know. I did that particular part of the presentation with a physician conference one day, and they said it was very relevant, and I agree it is relevant. One thing that I wanted to mention, especially for students, whether you're respiratory students or nursing students, any kind of student in the medical field, it's very important when we're dealing with patients, whether they're patients on a ventilator, not on a ventilator, or whatever, that we really wrap our heads around everything going on with these patients. That's how we function effectively in our setting as respiratory therapists. If we didn't, we'd be at the very least confused about things and ask for people's help when we need to do something right then. We'd be asking for people's help. But if we know everything that we can about these patients, then we should feel better about things and such. So I'm going to give you a very broad overview today of airway issues that we encounter and choices that we use in managing these airway issues. And our ventilator patients are in a sense unique because they are hypermetabolic. You're going to hear that word all through the presentations, and which you'll learn more about in that regard. For us, this means these patients are going to be breathing at a higher rate than they normally breathe. Indeed, we've gotten patients from many areas, depending on the degree of burn, who could be breathing 30 or 40, even 50% higher than their normal respiratory rate for that age group. So that sets the stage with that respiratory rate and their breathing patterns. It sets the stage for what we can and can't do effectively as far as ventilating these patients. Bear with me. Clayton, which one do I use for the, excuse me. So I want to begin talking about mechanical ventilation. And let me say that we don't get many mechanically ventilated children in our neck of the woods compared to the larger hospitals. Indeed, maybe we'll get 4 or 5 a month, on a slow month, maybe 1 a month. And our aim is to get these kids off these ventilators as quick as possible. Why? Because the longer these kids are on these ventilators, they're more prone to problems, such as ventilator-associated pneumonias, which is the next presentation I'm going to talk about after this one. Other issues that they have the longer that they're intubated is airway anomalies, such as tracheal stenosis, tracheal malacia, paradoxical cord movement, vocal cord polyps, just all kinds of different things. And so that's not only because they're intubated, but it's also because some of them require higher endotracheal tube cuff pressures than normal in order to ventilate them. Those are the very sick kids. Generally, we try to keep these cuff pressures down as low as we can, but sometimes in spite of our best efforts, they still develop these kinds of issues. And our patients who are on ventilators, they can be intubated and ventilated for very simple reasons, like they went to the OR for reconstructive surgery and they don't have any other comorbidities or anything like that. So in that kind of a situation, they might come out of there where they haven't been able to wake up, so we get them to the room, put them on the ventilator at very minimal settings, and in hopes that we can extubate them later on in the morning or the next day if they present to us later in the afternoon. Other patients are those that are sedated in flight, especially for long flights, patients with airway swelling, like from a smoke inhalation injury, or for iatrogenic reasons also. So I'm going to give you a brief refresher on mechanical ventilation, the ventilator modes that we use, and what makes these modes perhaps more suitable for our patient population than others. But first, let me say that these two concepts you must get down, not pat, but you must at least try to understand them if you hope to have any understanding of mechanical ventilation. And you certainly need to understand these as I explain how we ventilate our patients, because these play right into that, okay? And that is, when we volume ventilate, pressure is variable, and when we pressure ventilate, volume is variable. And I hope the camera can follow me, but it's hard sometimes explaining exactly what volume ventilation is, but you guys out there, you use these IV bags and you see volume as fluid. I see this empty bag that I've filled with oxygen as a tidal volume, if you will. So when we're volume ventilating, we set a specific tidal volume to be delivered from the ventilator through the ventilator circuit to the narrowing endotracheal tube, to the trachea, bronchi, segmental, subsegmental, alveolar ducts, atria, sacs, all the way down to the alveoli, in hopes of an effective gas exchange. Then that same volume comes back out where we can measure it as exhaled volume. So what goes in should come out. Now, for that volume to leave the ventilator to go through the circuit in the patient's lungs, it has to have something moving it. And we'll call that pressure, because it takes pressure to move this volume through that circuit. Now, as that pressure pushes this volume through that circuit, downstream in the lungs, there's resistance that's going to be met. Resistance from the continuing narrowing airways all the way down to the alveolar level. Viscous resistance, as we call it, which is the organs surrounding the lungs, things of that nature. And if your patient is breathing spontaneously, even his spontaneous breathing can be a form of resistance. Now, that's not even counting other forms of resistance, worse resistance, I'll call them, like bronchospasm, a lot of secretions in the airway, interstitial edemas, things like that. Those are other forms of resistance. So let's say delivering this 500 cc volume through that entire circuit takes 20 centimeters of water pressure, okay? That 20 centimeters of water pressure is going to deliver this volume with no problem other than the minimal resistance. Let's add a little more resistance to that by bronchospasm, interstitial edema, secretions in the airway, something like that. Now the ventilator has to generate more pressure to move that same volume into the lungs. Thus, when we're volume ventilating, pressure is variable depending on how much resistance that breath encounters on the way in. Pressure ventilation is a little bit more difficult to explain, but I'll give it a whirl. In pressure ventilating, we're asking the ventilator to deliver a preset pressure, again, from the ventilator through the circuit into the patient's lungs, preset pressure. And it just happens, bless you, and it just happens that once we get that pressure breath in the lungs, we can actually measure it coming out as volume. It's registered on the ventilator as an exhaled volume. So let's use that same model. Let's say of 20 centimeters of water being delivered into the lungs, okay? Under normal circumstances with minimal resistance, we might get an exhaled tidal volume of 400 or 500 cc's. But if you add other forms of resistance, as I mentioned, bronchospasm, secretions in the airway, interstitial fluid, that kind of thing, now we have that pressure breath coming in there, and it's going to meet its time limit and its pressure limit, and it's going to shut off in the face of those other forms of resistance. Then our tidal volume coming out will be less than that 400. Make sense? Thus, when we're pressure ventilating, volume is variable. Okay. All right. And so when we're working with ventilator patients, there's really things that you must know about these patients. And this is some of the things we need to know. There have been a few times in rounds over the years that I've worked there where I've actually asked in rounds, why does this patient have a breathing tube in? Why are they trached? Why are they intubated? Every once in a while, I get this response, really, that nobody knows. Nobody knows or understands why. You need to understand why patients have an airway in, because you're working toward getting that airway taken out eventually. So it's a good reason, these are good reasons to know why that tube is in. The respiratory assessment, we are so focused on the technical, on what's on the monitor and what's on the ventilator and what's in our blood gases and that kind of thing, that sometimes we forget there's actually a patient under there that we're trying to treat. This is a patient with a breathing pattern, with a respiratory rate, and they may be sedated, they may be awake. But anyway, we have to do that respiratory assessment and do our best to assess these patients' lungs and such in order to direct our care in that direction to get them off the ventilator and such. Our ventilator settings, we must know those, and not only know what the ventilator settings are, but ask yourself, are these settings appropriate for what I see with that patient? Is this tidal volume, this rate, is it working not only by blood gases or saturation on the monitor, does it look like it's working for them? It's always important to remember there are two respiratory rates, unless your patient is paralyzed. There are two respiratory rates involved. You have a spontaneous rate from the patient, and we have a mechanical rate from the ventilator. Again, that's if the patient hasn't been paralyzed. And what I call the adequacy qualifiers are actually your blood gases, because for all intents and purposes, they are qualifying the adequacy of ventilation and oxygenation. A lot of people, as far as oxygenation, will look at the saturation on the monitor and say, yeah, we're 100% saturation, we're cool. There's a lot of our patients that don't have arterial lines, so how do we assess the adequacy of ventilation and oxygenation? One might say, well, the adequacy of oxygenation, we look at the monitor and forget if it's 100% saturation, we're doing great. I have seen patients with unilateral pneumothoraces with 100% sat and a good waveform on the monitor. What's your best indicator of the adequacy of oxygenation in the absence of an arterial gas in an ICU? Your patient. Look at your patient. Ask yourself, do they look 100% sat? But the saturation on the monitor is 75%. Do they look 75% before you get all bent out of shape? Look at your patient. Fluid balance is important to us also. I mentioned a couple of things a while ago as far as forms of resistance. If our patients are quote-unquote fluid overloaded, well, they have a lot of interstitial fluid and or a lot of secretions in their airway, that's going to be difficult to ventilate those patients, and we would find out if those patients are being adequately systemically hydrated and work with you guys as nurses as well as the doctors to reach a good balance there. Hemodynamics are important also. Our nurses generally try to keep these mean arterial pressures with regard to fluid administration. Keep the mean arterial pressures at levels that are appropriate for that patient's age group. Medications is another thing that we need to know. You guys give a lot of medications throughout the course of the day. We are very interested as respiratory therapists in medications that affect not only the patient's breathing, but also their hemodynamics. And certainly we'd like to know about their chest x-ray to see how they're doing in that regard. So I'm going to go over some of the ventilator modes here with you. Some of the common ones that we use, and let me say that we don't use non-invasive ventilation a lot in our neck of the woods, primarily because some of our patients, maybe 30 or 40% of them, are burned in the face, so we wouldn't put a face mask on there, number one, because it'd be uncomfortable for them. Number two, we'd be putting a lot of pressure on their wounds, which could make them worse. And number three, they have a lot of, like, I want to call it salve, for lack of a better way of putting it, like polyans and stuff like that, which would make the mask slide. Now put this side up. I like to see synchrony between our patient and ventilation. Now remember, these patients are coming in and they're breathing 30, 40, 50% higher respiratory rates than they should be for that age group. They may also have weird breathing patterns, like paradoxical breathing patterns, where they're bearing down to breathe, which will give us an indication they might have some airway obstruction. They might be having difficulty inspiring, which might be an indication that they're having bronchospasm or something like that. So what we want to do is give them the kind of mode that would put them in synchrony, and SIMV does the trick. Synchronous intermittent mandatory ventilation, pretty much in a nutshell what that is. If you realize that you in your respirations as you breathe, you have an inspiratory phase and an expiratory phase to each of those breaths, okay? So what we try to do is match our inspiratory phase of ventilation with their inspiratory phase, thus synchronous intermittent mandatory ventilation. And we like this mode because it is a wonderful mode as long as it's used appropriately. I'm leaving out some of the technical terms so that don't confuse you a whole lot with that, but it's a matter of setting this SIMV and setting an inspiratory time and such to make it appropriate for these patients. Our choices of SIMV are here, as you see down here below. PRVC and volume control and pressure control. I'm going to go over those briefly here in a second. And one adjunct to ventilation that we use a great deal, that's the pressure support that you see here. I'm going to go over that also. PRVC is one of the adjuncts we use with SIMV, and it's basically pressure regulated volume control. And its function is, as it says, to regulate pressure while we are in a volume mode, okay? We like this kind of mode for our patients that have a lot of airway issues besides being just intubated with no issues, like maybe our ARDS patients, okay, or patients that have a lot of secretions in their airway or something like that. And there you see the benefits of the SIMV and the PRVC. We have patient ventilator synchrony with the SIMV, and we're regulating the inspiratory pressures also. Pressure support is a really neat mode, and we add that on SIMV, PRVC, and pressure support. What pressure support is as it says. It is a support pressure, meaning your patient has to be breathing spontaneously for them to get any kind of benefit from that support. Neat thing about pressure support, patient in pressure support can breathe as spontaneously, can breathe as fast as they want, as slow as they want, as shallow as they want, or as deep as they want. It keeps right up with them. Okay? Great mode of ventilation. And remember with pressure support too, that there, the thing at the bottom there, it says pressure modes, volume is variable. You've got to remember that also. Volume control ventilation, you notice it doesn't have SIMV next to it. So this is the volume mode of ventilation that is asynchronous to the patient's breathing. So if your patient is breathing 20 times a minute, you want this volume control mode to deliver 10 breaths a minute, it's going to deliver those 10 breaths a minute during a patient's inspiratory phase, during their expiratory phase, whenever. It's going to be out of sync with them. Probably needless to say, we don't use this that often. We do use volume control in patients who are paralyzed because it doesn't make any difference whether we're in sync with them or not. They're not breathing. So in those cases, we will use volume control. And again, remember, this is the volume mode of ventilation, so pressure is going to vary. The amount of pressure it takes to get the volume through those forms of resistance is going to vary. There's pressure control. Again, this is pressure control ventilation, of course, not volume control. That's the difference. So we have a preset controlled pressure that we're delivering into these kids' lungs. And again, there's no SIMV in front of that. So this is considered an asynchronous mode of ventilation. When do we use pressure control? We use it a lot with the wee ones, with the babies, and we don't get too many of those. But we do use it with the baby because we can control the amount of pressure going into their lungs. Now think of this, that if we use volume control on those babies, then we have unrestricted pressures that are being delivered depending on how much that baby imposes against those breast that are trying to come into their lungs. How much resistance do they impose? Try 550 or 60 breaths a minute. That's enough resistance to impose against those breaths. So long and short of it, that's why we use these pressure control modes of ventilation on the babies. But we do use SIMV pressure control on the babies to be in sync with them, okay? I'm going to try to explain the difference between PEEP and CPAP here, because there is a definite difference. And both of these are recruitment tools. And PEEP, whenever you hear PEEP being added to a patient's ventilator, it's usually when they are on a mechanical rate, 10 breaths a minute, 15, 20, or whatever. PEEP is associated with mechanical rate. You have an inspiratory phase to the breath, and that end exhalation, positive end expiratory. That's where your pressure above atmospheric is going to be set at 5 or 8 or 10 or whatever. So PEEP is a pressure above atmospheric, and that term is primarily used in patients who are on a mechanical rate. CPAP, on the other hand, is continuous positive airway pressure. It is a flat line pressure, a continuous pressure. There's nothing in there saying at the end of exhalation or anything like that, but this says continuous positive airway pressure. Order, follow those parameters, including an order that says wean as tolerated. And so from that point, again, we're going to try to get these kids off these ventilators as quickly as possible. Some of these terms you don't have to know a whole lot about. The plateau pressures, the IE ratios, we do try to keep our inspiratory to expiratory ratios between 1.1 and 1.3, and our PEEP levels between 8 and 12. There's some of our docs that don't like to put patients on what we would consider higher PEEPs, anything above 10, and that's because at that point, unless your patient's hemodynamics are really rock steady and okay, those higher PEEPs can affect their hemodynamics, and that's particularly important in patients who are already hemodynamically compromised with lower blood pressures from inadequate fluid resuscitation, or lower blood pressures from sepsis, lower blood pressures from medications. All of those can bring their blood pressures down. Okay, and these are the goals that are set. And there's some of our docs, some of our medical staff that will say, well, I don't want these PO2s less than 60, but these are guidelines that were set by our medical staff and also from the ARDSNet guidelines, which you may be familiar about from back in Y2K in the year 2000. It's important to remember too, if you don't have an actual arterial PO2, yes, you can look at the saturation on the monitor, but remember, it's our patient that we're concerned about there. So a good indice of whether our patient is oxygenating well is look at their color. If they're nice and pink, they're probably greater than 95% saturation, okay? We try to maintain our saturations actually above 90. And the reason we try to keep them above 90 is that 90% saturation on the oxyhemoglobin dissociation curve, 90% saturation is at the curve of the curve, if you will, and that is 60 PO2. That's an arterial PO2, 60 there. So our pH goal is 7.28 to 7.45, and again, depending on which faculty member is on, they may allow that pH, if necessary, to go down even lower. One of the biggest problems with the lower pHs is at lower pHs, there's a reduction in catecholamine sensitivity. So what's the significance of that? Well, if you have a patient on pressure drugs at lower pHs, they might not work. They might work some, might not work at all. So that's why we don't allow those pHs to drop down too low. On the other hand, if your patient is not on pressures, you're really not concerned about catecholamine sensitivity right at those lower pHs. And that's why more and more every year I see some docs allowing these pHs to get lower and lower. Okay. Factors limiting the effectiveness of ventilation, I went over them previously, and I'm going to go over them very clearly here in the next few minutes because I have some slides to show you, some images to show you. One of the factors, again, that limits the effectiveness of ventilation is our patients, not only their respiratory rate, but their breathing pattern also. okay? What else? The depth of breathing, Valsalva. A Valsalva type situation, if you have a child breathing and they're bearing down, many of you are nurses already, if you see a child bearing down, he's probably trying to poop, okay? But that is resistance against an incoming breath from that ventilator. In volume ventilation, that means the pressure delivery is going to be higher. In a pressure mode of ventilation, that means our expired tidal volume coming back is going to be lower, just like I mentioned a while ago. 3rd-degree circumferential burns, I have an image of that to show you in just a little bit. The same with fatty liver infiltration or other compromise to the diaphragm, like a binding dressing around the diaphragm. That's a form of resistance against which the diaphragm has to work so the lungs don't get good vertical expansion, okay? Smoke inhalation injury is another. I have a few slides of that. And the same with oral or facial burns. Now, I talked briefly about sedation a while ago, and I'm going to talk briefly about it again because Gene McGowan and others are going to speak about these kinds of sedation. Les Clayton already has these kinds of sedation that are used. Myself and Gene and Vicki Walker, who I'm presenting for this next presentation, we used to be a member of the Shriners flight team for the better part of 15 or 16 years. We used to fly down to Mexico, Nicaragua, Honduras, Belize, Panama, Yucatan, South America, all down there to pick up these children, and we learned a lot. And we learned a lot about the use of these narcotics, analgesics, alpha-2s, all of that, and how they do with these kids when we're in flight. Because, for example, with some of these narcotics, I'm sure you guys know that they're given on a dosage scale. And it's not until you get about to the middle of that dosage scale that you start seeing problems with hemodynamics or respirations or both, okay? So we try to control those medications as such. But if some of those medications are in fact causing a little bit of respiratory depression, and you go up into higher altitude with that child, where the partial pressure of oxygen is even lower, now you got a little bit more of an oxygen problem. Okay, and that is addressed in a whole different presentation, but I'm sure you get the idea there. This is a circumferential 3rd-degree burn around the chest. I have tried to get images of circumferential 3rd-degree burns that haven't been treated with escharotomies, and I just can't find them anywhere. But if you can imagine, this chest is just like a football, an inflated football. You squeeze on it, and there's no expansion characteristics at all. Imagine that volume breath trying to get through that circuit into these lungs. The lungs will expand a little bit inside, but the resistance imposed by this leathery surfaces makes it more difficult. Therefore, if you're volume ventilating, it's going to take more pressure to meet this form of resistance to deliver that same volume. This child actually had inspiratory pressures in excess of 60, like 60 to 62, somewhere in that vicinity. When they did these escharotomies and physically released the chest wall, those inspiratory pressures came down into the 40s. So this makes a big difference as far as our ability or inability to ventilate, for that matter. Now, this is a post that was done on a child, and I'm sure you've heard about liver enlargement with these kids from fatty liver deposition. And what I want you to notice too is the fatty liver deposition on this child. This is the diaphragm right here. And you can see that this liver is comprising almost cross-section, the whole cross-section of the abdomen there. It's very large. So that imposes a lot of airway resistance to us trying to ventilate these lungs on this child. Needless to say, they don't feed fats to these kids at Shriners for that reason, because those fats break down very quick and they can deposit in the liver. And we want to reduce a lot of risks involved after that fact. So now I'm going to play a video here. I might, Clayton's not here. Let's see if I can play it. This video is actually a bronchoscopy. If I can, bear with me. Oh yeah, I got it there. So what you're going to see here, I want you to watch at 10 o'clock, like up in this area here. This is a smoke inhalation patient, And this is pretty typical of what happens with patients who inspire smoke when they're in a confined area like a house or a room with a lot of smoke. The smoke has a lot of toxic gases, and I'm sure you've heard about that. But one thing that the smoke does is it adheres to the tracheal mucosa and even some of the bronchial mucosa. And over a period of about 48 to 72 hours, it morphs into what we call casts, which I'm going to show you pictures of also. So notice about 6 o'clock, at about 10 o'clock during this bronchoscopy, you'll see these little black areas up at the top left there. And that's actually smoke. You see some erythema in the airway also, redness in the airway. And that smoke, like I said, it goes through its morphing process, and it can break free in cast formation, which I'll show you in a second. And it can take off into the airways that you see there, and it can get even further into the smaller airways. If that happens, everything distal into the smaller airways is going to be affected. We're going to have a decrease in our saturations. We're going to have an elevation in CO2, or one or both of those. Why? Because there's no communication up in those airways from incoming breaths. They're hitting that. So you have the problem with increased pressures on the ventilator and with what's going on in the back of that, okay? And this is a cross-section actually from a animal model. And what you see is a cross-section here of a trachea. And there's a lot of secretions here. And again, I have to refer back to these forms of resistance. I don't know if you're familiar with Poiseuille's law, but Poiseuille's law says when you reduce the diameter of a tube by 50%, it increases resistance fourfold. What does that mean as far as ventilating? Again, you have the volume breath coming into this airway. You see very little clearing there for that breath to get through. When it meets that resistance, it increases its pressure to deliver that volume through there. And again, if you're pressure ventilating, then your return volume is going to be a lot lower. Here's another image of that. And this is real cast formation here. They look like little gummy bears, for lack of a better way of putting it. And these casts have actually formed into, I don't know if you noticed, but takeoff. We call them takeoffs for airways that come off of the larger airway. And again, everything beyond that is affected. You have elevated CO2s and a compromise in your PO2s also. We really try to reduce the risk of all this cast formation and the problems that it caused two ways. Number one, adequate systemic hydration. If your patient is adequately systemic hydrated to where your mean arterial pressures are greater than 60 or whatever they should be for a particular age group, then you're good. We also give these patients what we call an inhalation protocol, which I'll show you here in a second, where we give them for 7 days, every 2 hours, we give them a treatment of either mucomist and albuterol or heparin and saline. Back in 1986, there was a doctor named Dr. Garcia who worked at Shriners who did research on heparin, and he found that heparin is a mucolytic, like mucomist is, or acetylcysteine, whichever one you want to call it. So we try to reduce the risk of that happening by providing adequate systemic hydration and those nebulizer treatments. This is a cast that was removed from a patient who was a patient at Shriners who was in a prone position in the OR, and they were doing autographs on this patient's back when all of a sudden the sat dropped and the entitled CO2 rose. They flipped the patient over, suctioned them out, and this is what came out. It's almost a perfect cast of bronchi, and on that end over there is where the trachea would be. So, and this is cellular debris, blood, polymorphonuclear leukocytes, just all kind of gunk in there. And again, we try to reduce the risk of this by providing adequate systemic hydration, suctioning them as often as we need to, and providing them this, or what we call a protocol, inhalation protocol. This is that acetylcysteine nebulization protocol that we use that I mentioned a second ago, where we alternate the heparin and the mucomist, and we also give them albuterol. Why do we give them albuterol? Because sometimes they have reactive airways as a result of the irritant effect of that acetylcysteine. So we give them the albuterol to counter that or reduce the risk of that happening. We don't like to give the albuterol unless we absolutely have to, but in this case we have to, especially if they're a severe inhalation injury. Why don't we like to give it? Because our kids already have elevated heart rates and we don't want to make them any worse. Now, that said, we haven't had too many kids that have had worse elevated heart rates. We've had a handful of those who actually went into SVT with albuterol. So we're very careful about who we give that to. And I'm going to go over, just in a couple of slides here, some of the forms of airway security. This patient actually came in from Mexico, and he has, I forget what you call this particular kind of apparatus to keep the endotracheal tube secure. This is actually, this is probably the only apparatus that they could use at the time to secure this tube, but this is actually also a very dangerous apparatus. Why do I say that? Because if you can slide this thing down like that to the child's neck, the ET tube can come out. If their airway is already swollen, okay, around that endotracheal tube, when you come out with the tube, it can cause bigger, they can even die, okay? So you have to find another way of providing security, and usually what we do is this. We will retape the endotracheal tube where they have security above the ear and below the ear. Now this is for oral intubations. This child also, you can clearly see that his upper airway is swollen. That would be a medical emergency if this tube came out. So we got to be careful of what we bump into these kinds of tubes because they can accidentally be extubated, and again, we have a medical emergency, which is not a big problem. Usually we have docs around. We have cricothyroidotomy kits as well as tracheostomy tray there in the unit if they need an emergency airway. These are other types of airway security. The middle one and the bottom one, of course, are mannequins, and the one on the top is another form that I've seen used where they will get sutures and secure the tube to teeth. I have seen them secure endotracheal tubes to maxillas, where they put what they call a red rubber catheter. I call them Robinell catheters, through the nose and out the mouth, and they'll secure the tube like that until they can attempt reintubation nasally the following morning. I'm going to talk briefly about the kind of tie that we use there at Shriners to secure endotracheal tube, and these kind of ties also are used by our nursing staff to secure their NG and Dobhoff tubes off successfully. And the way it works is they'll put these red rubber hoses through the nose and bring them out the mouth, and as you can see, there's a piece of umbilical tape that's secured to the tips, and as we retract this back through the nose, you can see at the mouth level there with this this tie is going into the mouth, and once these red rubber tubes are completely out of the nose, it leaves the ends of the septal tie out of the nose there, and I realize that this cloth tape is going around the nasal septum and coming back outside. And this is the end result when that tube is secured with a septal tie. You can even see the nurse's NG tubes and Dobhoffs tied off to that. Okay, I'm going to talk briefly about the weaning process here. And this is an abbreviated version of the criteria that we use to wean these patients from these ventilators. It's called the Hedley-White criteria. And I'm going to let you look over them briefly. But briefly to say what we do, we want these children to be breathing spontaneously. We want them to be awake. We want them, of course, to have good blood gases, minimal FiO2 coming off the ventilator. Sometimes these kids, after you wake them up, they try to get out of the bed. That actually used to be a criteria for extubation for anesthesiologists in the OR, is that they can lift their heads off the bed. So we want all of these things to be in order before we get them off of the ventilator. And of course, no muscle relaxants. A sedation vacation, that's usually what the nurses do at about 4 o'clock in the morning. They try to take away, I say try, sometimes it doesn't work that well. They try to take away these medications so that these children can wake up over a 3 or 4 hour period in hopes of extubating them at about 8 o'clock in the morning. As far as extubation, what the preparation for the extubation is where we have supplemental oxygen set up and on and ready to go. The child's head elevated at least 30 degrees to reduce the risk of aspiration. And we also ask the nurses to remove any kind of gastric contents from the stomach, again, to reduce the risk of aspiration. There's always an airway package, if you will, on standby with everything intubation in that package, just in case. And then we extubate these children, and we put them on supplemental O2. So usually they're on 30% FiO2 or so prior to coming off of the ventilator, and we will put them 10% higher than that once they're extubated. Why? Because we're losing the PEEP. Remember, we're taking them off that 5 PEEP that we normally use for these kids to help maintain alveolar patency. And we have them cough, deep, breathe every couple of hours, suction PRN. Over on the right, you see post-extubation stridor and wheezes and such. For those kinds of things, and before we think about giving them medications to treat those issues, we really want to know if they're caused, like in cases of the stridor, are they really caused by swelling? Is the wheezing really bronchospasm, or is it a noise like a whistle around and through an NG and a Dobhoff area in the nose there? Is that being referred down here in the lungs? So in the cases of the wheezing, if we hear them wheeze and we hear that wheeze auscultation, look at the patient. Do they look like they're in bronchospasm? If they don't, we're not going to give them an albuterol treatment to relieve the wheezing, okay? If they have a history of wheezing, of reactive airways like asthma or something like that, we would consider, again, we have a heart rate to deal with. Their heart rates are elevated. Any kind of these medications that are administered to them can make things worse. So our first line, as far as airway issues, particularly stridor. If we hear stridor, we already have them on this cool aerosol that's real close to their face. If we need to, because the stridor continues, we'll put them on high output aerosol, just like a really thick fog. If the stridor continues, we'll put them on Heliox. That's 70-30 Heliox, which is 70% helium, 30% oxygen. Heliox has the same viscosity as the Airway Breathe, but it has roughly 1.5 times less density than the Airway Breathe. And I would venture to say even with our worst stridors, we have at least a 98% success rate with it in the short term. Now realize that doesn't fix the original problem that caused the stridor, but it does help. So this summarizes everything. The ventilator modes and parameters are patient specific to their needs, and we ventilate per ARDS and NET guidelines, and we use SIMV, PRVC. I didn't put there also that we use pressure support. Those are the preferred modes and adjuncts of ventilation that we use. We prefer lower mechanical rates on the ventilators. Why? These kids are already breathing fast. We don't want to superimpose a higher rate on them. It could cause a lot more problems. And again, we prefer pressure support for weaning and are aimed to extubate within 24 hours of meeting extubation criteria. Now I'm going to show you a couple more videos here. This is probably one of the most important bronch videos that you'll ever see in your entire career, because this is a patient that was extubated. Shortly after extubation, they were given ketamine to settle them down, of course, so that they could remove staples. They don't do this anymore. Usually they remove staples when they're on the ventilator now. But this child was a little bit different a few years ago, and this child was showing stridor, a little bit of wheezing, difficulty breathing and such. So our anesthesiologist got his bronchoscope. He locked and loaded an endotracheal tube down into the airway, and he's looking at the glottic opening here. And this is the result of a jaw thrust. That's why this is a very important video. Remember, this child was stridorous with wheezing and such, anesthesiologist is ready to intubate this child. He didn't have to. It was a mechanical issue. All he had to do was lift the jaw and position the kid's shoulders and avoided an intubation. Okay? And that's why I said we really look into these things when we hear stridor, when we hear wheezing. We do the simple stuff first. In this case, open that airway wide open. There's no erythema indicating swelling. There's nothing but pink here. So they position this child appropriately with a sniffing position, shoulder roll, and needless to say, they took out the bronch and the endotracheal tube, woke the child up, and he was fine. He didn't require anything else. So, and this is kind of the total opposite here. This is a child that has swollen artenoids that are actually caving into the glottic opening, which actually caused the stridor in this child. And you'll see that glottic looks like two balls there. They're just caving into the upper airway there. And that caused a great deal of stridor and difficulty breathing in this child. This child had to be re-intubated, and overnight they gave him some Decadron. The next morning he was successfully extubated. That's the same one, I apologize. And this is actually a baby who had an upper airway swelling issue. This baby wasn't given Decadron the night before he was extubated, and we can see how swollen the airway is here, the arytenoids caving in. At the same time, you have the bonnet of the epiglottis coming down and partially occluding the airway. This child also had to be re-intubated, given Decadron, and the next day he was successfully extubated. So you see, some of these kids we do have to have re-intubated, and some of them we don't. We have to look at everything going on with this child. Do they have a history of this kind of thing going on? We should have some kind of indice, whether or not, bear with me, we should have some kind of indice prior to extubation as to whether we can extubate these children because they have an upper airway issue or whatever. And prior to extubation, we'll drop this cuff down. We'll take all the air out of it. If we hear a leak, that's a good indice that these children can be extubated. Okay? So I'm going to go over as quickly as I can some mechanical ventilation techniques here. A lot of these you learned in school, but there is some logic behind ventilating children or adults with these manual resuscitators. And you're ready to do whatever you're going to do with it. Know exactly what you want to do with it. Do you want to improve oxygenation? Do you want to improve ventilation? Do you want to improve both? It's very important that you know that, because there are specific techniques that you can use in ventilating these kids that'll work better than just putting them on the manual resuscitator and bagging the heck out of them like that. So I'm going to go over time permitting spontaneous breathing patients, bagging spontaneous breathing patients without airway issues. Those are the kind of patients that are coming out of the OR. They don't have any comorbidities or anything else other than they're not waking up. I'm going to talk a little about patients on high ventilator rates that you're taking off because you have a need to bag them for whatever reason that is. Patients on high PEEPs or end expiratory pressures, patients on high CO2s, and hypoxic patients. So here's your spontaneous breathing patient coming out of the OR. And these patients you can either put you can connect the manual resuscitator to them and just allow them to breathe if they have a spontaneous rate. They don't have any other lung comorbidities like pneumonias or anything like that, secretions in the airway. They just need to stay oxygenated because they're breathing shallow going to their room. So you can put this manual resuscitator on them, let them breathe off of it, or you can support their breathing by breathing synchronously with them, okay? Now, if you have a child that you're breathing synchronously with them, they're breathing 60 times a minute, you got to get that breath in there really quick. A 16-year-old who has a longer inspiratory time, a little bit longer squeeze. It's very important. Now, I wanted to mention to you that years ago I worked in a major hospital in the Houston-Galveston area, I worked as a respiratory therapy supervisor on the day shift, and one day, myself and the other supervisor with me got 3 code calls in about 15 seconds. 2 of the codes were on the general floors. One of them was in the ER. The one that was in the ER, the docs usually went down there and they intubated the child, ventilated the child until we had time to get back down there and take over and then take this child to the ICU, whatever ICU. This child was wrapped up by a Portuguese man-o-war on the beach, and he died from an anaphylactic reaction from that. So we go to the floors, we take care of those 2 patients, if you will. Basically, it was a directing traffic thing where we told some respiratory therapists they'd go back to their assignments, others to stay there. 20 minutes later, we got down to the ER. We're about from here to that wall over there, and we can still see the CPR is going on. When we get up to the gurney there, they're still doing CPR on the child, and they call it right when we get there. Let's call it off. We're not getting anywhere. And I looked at the anesthesiologist, and he says, we couldn't get this child's PO2 greater than the mid-40s. I said, do you know how long the oxygen supplying that manual resuscitator has been off? Yes. You got to think about the simple things when you pick up this bag. Make sure it's connected, make sure your flow is on, and you're ready to rock. Make sure you got the right size bag also. So you want to ensure it's got the proper flow, PEEP valve in place and properly set. Connect the bag to your airway and you stabilize it. You don't want that bag to be moving all over the place. And again, for this model patient, you can have them breathe off that bag, or you can synchronize your breathing with them. Now, as far as hypoxic patients, remember, you're trying to fix oxygenation here, not CO2, so you don't have to bag the crud out of them like that. You're trying to fix the oxygenation. Again, make sure your manual resuscitator is connected to the flow meter. The flow is on at the appropriate level of flow. PEEP valve in place. And there are a few techniques here. You can let them breathe on that 100%. If you see the saturation coming up, you really don't need to do any more. You're fixing their hypoxia, okay? You can help them breathe synchronously. Slower, deeper breaths, if those kinds of things don't work, slower, deeper breaths are a lot more effective at ventilating patients than these faster breaths. Why? I don't know if you've ever seen lungs expand under, what is that called? Under electron microscopy. But when you bag somebody or an animal like that, their lungs don't open like this. Depending on the compliant and the non-compliant areas of the lungs, they open like this, little bits at a time. The longer you hold that bagging breath in, the more of those are going to open up over time if your blood pressure can afford it. You don't want to hold that breath in there too long. It can't affect your blood pressure. So slow, deeper breaths. Sometimes rapid breaths work. That sounds contradictory to what I'm saying, but rapid breaths provide what we call breath stacking, where you're going real fast. You don't allow exhalation to take hold of completely. So you're holding those lungs open and you're recruiting more. We generally don't like to use that, only as a last resort. Inverse IU ratio ventilation, when we have a long inspiratory time, short expiratory time, and then another long inspiratory time. Again, that can affect your hemodynamics. So you can say that you should fix your hypoxias in this order, okay? Simple to complicated. As far as high ventilator rates, basically what you want to do is match the rate that you're taking them off the ventilator with, okay? And while you're matching that rate, it's a good idea to have a pressure manometer on your manual resuscitator because you're not going to get a returned exhaled volume with these bags. You know you're putting pressure in there, but you're not going to get an exhaled volume. So what? So you want to match the pressure on this bag with the pressure it took to ventilate them that's on the ventilator, okay? And again, the PEEP valve attached and such technique choices, you want to ventilate synchronously with them, and you want to ventilate to the inspiratory pressure that it was taking to ventilate them on the ventilator. As far as elevated CO2s, remember what you're working on here is to eliminate CO2. So if you're doing this with that bag, you're not giving enough expiratory time, which is what you need to effectively ventilate. So slower rates, okay? More time to exhale. even deep breaths and slower rates, okay? And you want to ventilate, or you can ventilate at higher pressures if you're ventilating with pressure ventilation, or higher volumes, deeper squeezes of that bag, okay? Whoops, I lost my click there, okay. Manual ventilating with high PEEPs, these are the difficult kids to ventilate because you're going to have to match the PEEP that you're coming off the ventilator with. So if your ventilator is set at 15 a PEEP, you got to set your bag at PEEP also, but it's not that easy. What we have to do is a two-person thing where you're bagging these patients at the same rate, the same PEEP, okay, as they're coming off the ventilator. So while the ventilator is firing breaths into their lungs, on the inspiratory phase of one of those breaths, you want to clamp the ET tube, you're holding that breath in. You disconnect them from the ventilator, connect the manual resuscitator, release the clamp, and begin bagging them, okay? That's why you got to have two people doing that. It's a very difficult process. But they're not losing that PEEP because they're coming off the PEEP. You have that tube clamped, okay? And normally you don't have to worry about that kind of situation. There will be respiratory therapists around to help with that. Can't read the top part there, but this is, let's see, for improving oxygenation. Clayton, how do I read the top part there?
Oh yeah, here we can move that far. What I'll do, I can actually, this is pinned at the top, and so if you click that, it'll go away.
Oh, cool.
Sorry
Cool
about that,
patient.
should have started that way.
Now, before I begin on this, let me say, I'm not going against AHA standards here. What I'm doing is offering here other things that you can do during codes if what you're doing is not working. Usually in codes, you're trying to fix two things. You're trying to fix your CO2 and you're trying to fix oxygenation, or one or the other. But in codes, what you want to do is remove this PEEP valve. Why? You have very little of any blood pressure. This PEEP valve is holding a breath in the lungs, okay? So it's putting pressure on your interthoracic vessels, okay? So you're already compromised with your blood pressure, so you want to take this PEEP valve off. And so 100% FiO2 and deep recruitment breaths, okay? Deeper recruitment breaths. Longer inspiratory times to improve oxygenation, for improving CO2 removal. Longer exhalation times if your patient can afford that, or increased respiratory rates or deeper breaths, okay? It's kind of tricky in code, but these are other things that you can try to fix those things depending on what's going on. Sometimes in codes you might have patients with just an elevated CO2 and their oxygenation is okay, meaning their saturation is 90 and their PO2 is in the high 50s or something like that. So you have to keep track of what you need to fix in the code. Not continually bagging the same way all the way through the code. If something's improving, get off of that and then do some other technique to improve the other thing. I think that's it. I don't get any more clicks here, so that's probably it. Any questions? Okay, so the next presentation is going to be on